Hi, everybody. Happy Tuesday. We are getting to be close to end of our wonderful epilepsy 2 days. Thank you for joining me today. The first hour, actually, I'm going to present my video recorded lecture on neurometabolic disorders, but I'll kind of hang around here in the background if you guys have any questions after that. And then I'm going to continue for a second hour at 4 p.m. And I'm going to give a live lecture on non-epileptic seizures. So thank you for joining. And Stephanie, hit it.
Hi, I'm Dr. Maija Steenari. I'm one of the epilepsy doctors and neurologists at CHOC. Thank you for joining us today. I'm going to talk about epilepsy and some neurometabolic disorders and why is it important to dig in a little bit deeper if we can find the underlying reason for your child's epilepsy. So, little intro first, what are we talking about today? So, what are neurometabolic disorders? They are very rare disorders, often quite devastating. And what's often happening with little ones is they have symptoms from multiple different organs. So not only brain is affected, but they can have vision loss, they can have hearing issues, there can be cardiac problems and whatnot. So it's important to make the correct diagnosis so we can see if any other collaborations are needed. I'm going to give you a very, very quick overview of some metabolic diagnoses. And I'm going to give you some idea when should you or your doctor, when should we suspect a metabolic condition causing the seizures. And then I'm going to touch on a little bit if there's any specific treatments available for particular syndromes. So how is it that a metabolic disorder can cause brain problems? So many of the inborn errors of metabolism, they can interfere the key functions in the brain metabolism. For example, there might be a problem how the energy substrates that the brain cells use are transported or used. There can be an excessive production of certain products, or there can be loss of production of some very key components in the energy production of the nerve cells. There can be a problem how the neurotransmitters work in the brain. The metabolic conditions can cause an issue how the blood flow is regulated in the brain. Or there can be a problem in the transportation of significant necessary energy components or substrates for example, neurotransmitters to the brain, and then we see the end results. Some disorders, there might be a accumulation of some compounds that can cause directly the nerve cells to have some damage. So when do we suspect an underlying metabolic condition to be a cause? If your child is otherwise developing normally and then has 1 or 2 seizures, typically we don't do an evaluation initially. But if there's any other key features like developmental delays, autistic features, if the seizures are very difficult to control with 1 or 2 medications, if there's a movement disorder associated with epilepsy, if there's other organ systems involved, if there's any family history that's suspicious, or sometimes we can see some specific imaging finding when we do an MRI as part of evaluation that then clues us in to look for metabolic cause. Now, sometimes you hear that, well, all the babies are screened for metabolic conditions, so it's not that. That's correct. We do have several known metabolic conditions that are screened on the newborn screening when they do the blood drop to the paper and send it to the newborn screening program. But it's still very important to look. Sometimes these metabolic conditions start showing symptoms or products in the body at a later age. So we do still want to do further testing. I'm going to give you some ideas of few different families of metabolic conditions that can cause epilepsy and some developmental disorders. First of all, there can be a problem how the proteins are break down in your body. And sometimes there can be a problem of how the lipids and fats in the body are either broke down or stored, and then there can be an accumulation of a product that's toxic for the nerve cells, and then that can present as seizures, that can present as cognitive disorders, behavioral problems that can cause problems how you move your body, and that can cause also structural damage in some cases. Then if I go more into detail with breaking down the fats, so fatty acid oxidation, sometimes severe seizures can be a presenting sign of defects in fatty acid beta oxidation. That's a process where your cell produces alternative sources for energy. It's quite typical that we find out of these disorders when the body is in a stressful situation and there's a high energy demand, and the system then fails, and then we have a decompensation, and then we start having symptoms of severe seizures, changes in the mental status, and whatnot. Sometimes the problem can be in the urea cycle. So the metabolic mechanism for the nitrogen detoxification and removing that from the body. There's very fine-tuned process of enzymes breaking down the products, and any parts of that process there can be a defect. The system has a roadblock, and then there's an accumulation of a toxic material. If there's a defect in one of the enzymes, we often see hyperammonemia. So the ammonium level in the body gets really high, and then that leads to overwhelming changes in how the child looks. They're very, we call encephalopathic, so they're not themselves. They're very unresponsive and tired. They often have also seizures and can have a very poor tone and difficulties with even maintaining feeding or breathing. And that can be brought on by, for example, infection and fever. So what do? We do a lot of things as far as workup for looking for an underlying metabolic condition, but there are some kind of first line testing that we often like to do when we meet a child when there's a suspicion for metabolic cause. So we look at the blood, we look at some key features giving us some clues on what's going on. We look at the lactic acid level, we look at the ketones, we look if there's any high ammonia level, we look at the child's glucose level in the blood. We can actually measure the amino acids in the blood and see if there's any low levels or any high levels, giving us some clues on what's going on. We can look at the carnitine levels, and we can look at the acylcarnitine profile. We can look at prolactin. That's one of our markers when we suspect neurotransmitter disorder. We also take a urine sample, and we can look at organic acids that are produced by the body and spilled to the urine, and we can see what the levels of the organic acids are. We can do a spinal tap, so we can look at the cerebrospinal fluid to see if there's a high or low level of glucose. We can look at the lactate. We can look at some of the neurotransmitter levels. We can look at amino acids and some vitamin levels as well. We can take an image of your child's brain. We can do an MRI of the brain. And some disorders have very specific abnormalities that we can see in the MRI, and that can gives us clues on the diagnostic pathway. There's also a magnetic resonance spectroscopy looking at lactate peaks and a few other products in the brain that we can then move our pathway to other diagnostic testing. And obviously nowadays genetic testing is quite popular, and we test for some known mutations in our genetic disorders, neurometabolic disorders, in our epilepsy panel, for example. So I'm going to give you a few patient cases to kind of give you an idea what kind of symptoms some of these patients have, and why metabolic testing and evaluations make a difference. So I'm talking about first of this little boy. He had some events that started before his first birthday. So one of the events, for example, was described, he was sitting and eating, and then he suddenly lifted his both arms overhead, screamed like he was in horrible pain. And one of the family members picked him up and calmed him down, but then he just started screaming again, and there was no reason. All of a sudden, he turned back to baseline, and he was fine. The parents just took him to the ER because this had never happened before. They did some basic evaluations and everything was fine, so he was sent home, and they were like, we don't know what that was. So when he was about a year and a half, he started having episodes when he was walking, and then all of a sudden just became floppy and just fell over. And this happened quite frequently. He was all fine, and then all of a sudden he was very kind of floppy, fell all over the place, hurt himself. And initially there were weeks in between these episodes, but then he started having them more frequently. Parents were quite keen into him and figured out what was going on. They felt like he had more of these spells if he didn't eat. Sometimes the kind of episode lasted for a longer time, and sometimes it kind of, they gave him a snack and then it went away. There was no actual loss of consciousness, no shaking that we often associate with seizures and whatnot. As far as his developmental history, he was fine until when these events started around 1.5 years of age. At the same time, he actually stopped talking as well, so he had some regression on his language. So later down the line, this boy was actually diagnosed with the disorder called Glut-1 transporter deficiency. So what he has is, we all know that glucose is your essential energy source for your brain cells. So there's a transporter that transports glucose through the blood-brain barrier. So from the blood, so when you eat a meal, the glucose is in your blood, and then it's transported by this transporter to your brain, and then your brain cells can use the glucose for energy. But he had a defect in a gene that builds those transporters. So no matter how much glucose was in the body, not enough glucose went to the brain. And this is a problem if brain cells don't get energy to function. We often see seizures as a result. Anytime when there's a dysfunction in the brain cells are not working quite normally. Seizures are often a symptom of that. There can be a movement disorder, there can be some behavioral changes, there can be learning difficulties, there can be even movement disorders as a symptom of low glucose level in the blood. And why the diagnosis of this is very important is no matter how much medication we give, the brain is still lacking the energy source. And we are not fixing the problem, but there's actually a treatment. So we can use ketogenic diet as a treatment. So we step over the problem where the glucose doesn't go to the brain. We provide the brain a different energy source. If the brain cells have two options, they have glucose and then they have ketones from fatty acid. If they have a choice, they always pick glucose because it's easier. But if there's no glucose available, then the brain cells are like, okay, fine, I'll use ketones then. So when we provide ketones through ketogenic diet, then we provide a constant energy source for the brain and it can function normally. So making this diagnosis helps us pick the right treatment, not being a medication, but actually certain types of foods to help these kids. Actually, the ketogenic diet gives a pretty good prognosis for kids who have glucose-1 transporter deficiency. They can be seizure-free by this diet only, and often their cognition also improves and their movement disorder and behavior can. Our dietitians from CHOC have another talk from ketogenic diets, so please refer to that talk for further details. But I'm just going to mention there's different types of ketogenic diets that we can figure out what works best for your child. There are some specific features when we use ketogenic diet to improve seizure control as well. So not only if there's a glucose-1 transporter deficiency, sometimes we use ketogenic diet for refractory epilepsies as well. Another group of disorders I wanted to discuss is mitochondrial disorders. And why mitochondrial disorders are so important to diagnose is mitochondrial is like the energy production of every single cell in our body. So not only in the brain, but on your muscles, on your heart, on your eyes, on your ears, on your belly, everywhere. So every single cell uses mitochondria as their battery. And if there's a problem, there can be multiple different issues within the mitochondria and the energy production. But if there's a defect, either in the breaking down the products that the mitochondria uses for energy, or within that machinery when mitochondria makes the energy, that can cause multiple different symptoms and signs. There can be stroke-like symptoms in the brain. There can be changes on the myelination in the brain. Often there's seizures, especially myoclonic seizures are quite common. There can be a problem of balance and walking called ataxia. There can be some symptoms that almost look like Parkinsonism, so some tremors and whatnot. Migraines are quite common. Learning difficulties or decline in learning is quite common. Behavioral issues and symptoms, anxiety, depression can be a symptom from mitochondrial disease. And then we look at other organs as well. Vision, hearing, as I mentioned. Heart is another very important a muscle or organ that uses a lot of energy. And then liver, You can have diabetes as a sign of mitochondrial dysfunction. There can be, on an older woman, for example, infertility or menopausal issues. Muscle weakness, muscle cramps are quite common. And sometimes even kind of a tingling and pain in the body from neuropathy can be a symptoms of mitochondrial disorder. I'm going to give you an example of one of my little patients who had a mitochondrial disease. He had a deletion in the mitochondrial DNA. And initially he started with having some fainting episodes when he was exercising. So, his birth was unremarkable. His initial development was fine. And then around 3 years of age, he started having some fainting spells. So he was seen by a cardiologist. So he was diagnosed with the right bundle branch block, and he actually needed a cardiac pacemaker. He did develop severe cardiac arrest, but luckily that happened in the cardiac lab. So there was a cardiologist right there, and only 5 minutes of CPR brought him back, and the cardiologist placed the pacemaker then, and then since then his heart was dependent on that external stimulus to continue beating. Later down the line, about 6 months to a year later, he started having some issues of moving his eyes. One eye still turned, but the other eye did not, so his eyes were little off target, so he often complained double vision. He started having difficulties keeping his eyes open, so his eyelids were drooping, and he has had difficulties, especially towards the evening when he got tired. He had difficulty keeping the eyes open. He always had inflammation on his eyes as well, and the back of the eye and the nerve started to deteriorate, so his visual acuity started getting worse as well. His kidneys got affected as well. He started needing supplements for his potassium and calcium. He started having blood pressure issues. His feeding was an issue. He couldn't swallow well, so he needed a feeding tube. And then also the gut motility is quite typical with kids with mitochondrial disorder. So constipation or just not moving the food from the stomach and out is often an issue. He needed some steroid supplementation because his adrenal glands weren't functioning correctly. His hearing, his ears were fine. His hearing, there was no issues. And surprisingly, his brain actually was quite mildly affected. He didn't have seizures, just some mild cognitive delays. So he did well with that. But then unfortunately, few years later started having a lot of changes in his brain and also brainstem, and unfortunately eventually his mitochondrial disorder caused his death. I also have a little 3-year-old boy who I saw with seizures. He had an event first when he was 3. Parents described it as mouth movements, and he turned pale and then blue. He passed out, but nothing else. It lasted about 30 seconds. Parents initially thought that he was choking, but he all of a sudden woke up and he was fine. A few months later, he had another seizure. His head went to one side. He passed out. He had loss of consciousness. And after 30 seconds or so, he woke up. Then these events started happening more frequently, initially weekly and then daily. Some past medical history, so he was born full term without any complications. His birth weight was fine. His initial development was normal. During the time when he started having seizures, parents had also noted that he started having some difficulties with his speech. He seemed not to have as many words any longer, and he also started having some balance issues as well. He started having some tremors, difficulty with coordination, and parents thought at this point, because of multiple epileptic seizures, he was started on medication. Parents thought that the medication is causing all these problems. Then he started showing symptoms of worsening vision. Sometimes mom felt like he was not seeing objects, and he might just kind of bump into them. And sometimes he looked like he was looking for toys by patting around instead of just looking at it and going and grabbing it. His speech started to be more difficult to understand. Initially, he was talking in full sentences, and then he kind of went to 2-word sentences and then just using single words. And then he went into just kind of making sounds and moaning and pointing. His seizures were very difficult to control. At this point, they were happening every day, and he had failed few medications and currently was on 3 anti-epileptic medications. This is a classic story of neuronal ceroid lipofuscinosis type 2. It's a disorder where there's a mutation in a gene called TPP1 that encodes the enzyme that's named the same, TPP1. And what happens is in our bodies, in the cells, there's lysosomes that are kind of the cleaning houses of the cells. And this particular enzyme breaks down and does some of the cleaning process for us. When this enzyme is not working, the product that it's supposed to be getting rid of gets accumulated in the cell. And then eventually, this has been problem since the baby was born, but eventually as the years go by and the cells get full of the toxic material, we start seeing symptoms. Why the diagnosis of this disorder is very important is nowadays we have an enzyme replacement therapy. So we can give the enzyme for these patients, and we can protect them from progressing to the devastating end of the disease. Nowadays, we can actually make this diagnosis by genetic testing. So that's why we want to make the diagnosis very early, so we can start the enzyme replacement already before the kids are symptomatic, to protect the brain cells. So this was a very quick introduction of some of the metabolic disorders that can cause epilepsy as a symptom of the underlying disorder. Why, and I gave you some examples why making the diagnosis is so important. Sometimes just giving more anti-epileptic medications is not the right choice, but the treatment is actually special diets, limiting certain amino acids in your diet. It can be vitamin supplementations, or it can be providing enzyme replacement therapy. So I encourage you to discuss with your doctor if your child's epilepsy might be caused by underlying metabolic condition, and if further workup might be necessary. Thank you so much for attending today our lecture. Please enjoy all the other CHOC neurology lectures that we present today and in the future. And please don't hesitate to contact us if you have any further questions. Thank you.
Thank you, Stephanie. So we have a free half an hour. I'm gonna hang around here if you have any questions regarding the lecture that you just saw. And then I'll start at 4. I'm gonna give a live lecture on non-epileptic seizures. So you're welcome to ask questions around that time as well. Yeah, I think that's it. Thank you so much for coming in. Then just, you can, if you want, you can just write your question in chat, and then I can write back, or I can just pop my face back on the screen, and we can talk about things for sure. Yeah, so biotin. So biotin deficiency is one of the metabolic conditions that we look at. Right now, I don't have any little ones that we treat with that condition, but we do have few others with kind of vitamin dependent epilepsies, for example, pyridoxine dependent epilepsies. So when we find the cause or the reason, then the treatment is not always seizure medication, like I mentioned on the Glut-1 transporter deficiency. But for example, pyridoxine dependent epilepsies, we treat them with pyridoxine. And I do have few kiddos who are seizure free on that, but it's really important that to look for cause. I'm actually blocking out the name of the gene that can cause biotin respondent disorders, but we'll look for that. And nowadays, most of the epilepsy panels, they look for known mutations associated with these vitamin dependent epilepsies as well. So we don't look for single gene mutations any longer at this point. We'll kind of do bigger panels looking for 200-300 genes, or sometimes we even go to whole exome or even genome testing as well to find the reason. Sometimes we do biochemical testing as well. So we can test either directly the vitamins or the amino acids or products in the blood or urine, or we can look for the byproducts.